Acute decompensated heart failure. You want to get all the pieces of information on acute decompensated heart failure? You're in the right place. Without further ado, let's go. Hi everyone, I want to talk about acute decompensated heart failure. Acute decompensated heart failure. Acute decompensated heart failure means that there is a sudden deterioration, or if you choose, you can say there's sudden worsening of the symptoms of heart failure. And sometimes that could be misdiagnosed as a respiratory pathology if there's no adequate history or the physician is not aware of the knowledge of heart failure in the affected individual. Acute decompensated heart failure is very common and could be very fatal. In other words, could kill and kill pretty fast. What are the clinical features of acute decompensated heart failure? The symptoms could be in the individual, but all these symptoms will come up and be very serious and be going down the hill. Shortness of breath, worse than before. Paroxysmal notional dyspnea, Orthopnea, Tachypnea, Tachycardia, Crackles, and Rales. It's not that they will not be having these symptoms before, but perhaps just mildly, or they can still cope with activities of daily living. But when heart failure has reached the level of decompensation, it will get worse. Wheezing. The wheezing here is not due to pulmonary asthma. Well, we've known that is not all that wheezes is asthma, but asthma will wheeze. So in this case, the wheezing here is called cardiac asthma because it has symptoms like bronchial asthma, though it is caused by congestive cardiac failure. There will be massive edema or with ascites. The blood pressure could be increased and maybe down in severe cases. The jugular venous pressure will be raised for sure, and when hepatojugular reflux is examined, that will be positive. The heart sounds will be S1, S2, and S3, with or without S4, depending on whether we are dealing with diastolic dysfunction or heart failure with preserved ejection fraction. And of course, there's possibility of cardiac arrest. And that's why I said if care is not taken, it could be fatal. What are the possible differential diagnoses here? This could be pulmonary embolism. You remember I've just said that most of the times this could be misdiagnosed as respiratory pathology. So it's that serious and could be that sudden. So it could be misdiagnosed as pulmonary embolism and could actually be pulmonary embolism in affected individual with heart failure before. So could be asthmatic attack. The fact that this person is having heart failure doesn't mean he or she could not have asthmatic attack. So proper history and correct physical examination will guide. Acute or adult respiratory distress syndrome, pneumonia, pericardial tamponade. The history will give a clue, and of course the physical examination and subsequent investigations. In case of constrictive pericarditis or tension pneumothorax, has this person been diagnosed with COPD before they still having heart failure and the emphysema and everything like that, and or trauma somewhere, and the air is accumulating there. So tension pneumothorax is a possibility, but the physical examination will show. By the time you examine the respiratory system, you will know whether there's a pararesonance somewhere, dullness somewhere, shifting of the trachea, and so on. What are the investigations here? Because we might be dealing with many things, including myocardial infarction, so we need to rule out myocardial infarction pretty quickly. Troponins and CKMB will help. Complete blood count, is this anemia? Arterial blood gases to know what is happening to the respiratory system, and metabolism, whether we're dealing with metabolic or respiratory acidosis, whatever the case might be. Renal function, liver function, brain natriuretic peptides to know what is happening to the heart failure itself and the chambers. Electrolytes, sodium, potassium, chloride, bicarbonate, magnesium, calcium, and we can have an echo done, and of course EKG, because might be suspecting arrhythmia. Treatment, yes, very fast. Airway check the orifices for foreign body secretions, get them out as appropriate. Breathing, yeah, chest region, auscultate for crackles, for decreased air entry, to rule out all these possible related respiratory problems and make confirmatory diagnosis of heart failure there. Auscultate, percuse, check respiratory movement with abdomen, count respiratory rates, central cyanosis, peripheral cyanosis. Cardiovascular or circulatory system, what is the blood pressure telling us, the heart rate, the respiratory rate, fluid in and out, and auscultate for S1, S2, S3 plus or minus S4, depending on whether we're dealing with diastolic dysfunction or not. Cardiac monitor, of course, hook it up, and what is the O2 side telling us? When it's less than 92, you put the oxygen up. And of course, we need to know what the temperature is and the positioning, which I've stated in heart failure treatment. Please, you can just go over the presentation on heart failure treatment. That will be applicable here. Check the IV lines, CPAP or BiPAP. Atominate is okay for rapid sequence induction. You can give your lasers intravenously pretty fast. Atrial fibrillation might need synchronized cardioversion, plus digoxin and warfarin. Nitroprusside for severe hypertension, and nitroglycerin to relieve dyspnea, but depends on the type of heart failure you're dealing with. If less ventricular ejection fraction, give dobutamine and beta blockers. If preserved ejection fraction, that is, if this is diastolic function, please use your beta blockers cautiously. Okay? Can give you IV fluid and vasopressors like phenylephrine or norepinephrine. No dobutamine, no milrinone, no nitroglycerin, please. You can do your echo and EKG. You can send for surgery in case of mitral regurgitation or aortic regurgitation or aortic dissection. Intra-aortic balloon is applicable, and of course, there must be consult to cardiologists. The next presentation will be on precipitants of acute exacerbation. Thank you for listening. Kindly subscribe so that I can get these presentations immediately they are published. Thank you.